In this video, you will learn about the data element of medical decision making. Hey everyone, I'm Victoria. I'm a medical coder, auditor, educator, and content creator, and on my channel I provide tips, tricks, and tutorials to help you be successful in a medical coding career. And today we are talking about the data element of medical decision making for evaluation and management services. Honestly, this is probably my least favorite element of medical decision making, and a lot of coders will try to code just based off of the number of diagnoses and the risk and not have to split hairs with the data components if they don't have to. There's a lot of nuances of what can count where, so let's get into it. So if you have an E&M grid that's updated for the new guidelines, chances are good that your middle column on here is going to be the data column, or more specifically, the amount and/or complexity of data to be reviewed and analyzed. This is the portion where there is a little bit more of counting involved and a little bit more of tracking categories and how many of which categories and bullets you might need to meet that criteria. The different levels of data that we have are minimal or none, limited, moderate, and extensive. I guess minimal, low, moderate, and high would have just been too much consistency for us to have. Now, before we can get into the different criteria for these different levels and the different categories involved in these levels, we have to go through the definition of what the AMA determines as analyzed, because this category is the amount or complexity of data to be analyzed. So what does it mean to analyze something? So the AMA has a definition for us. They have it in our E&M guidelines. Again, I will link this below so that you can reference it. It's not something to memorize, but it is something you want to get very familiar with and reference back to. So this is our AMA definition of analyzed. It states analyzed is the process of using data as part of the medical decision making. The data element itself may not be subject to analysis, but it is instead included in the thought process, the provider's thought process for their diagnoses, for the evaluation and treatment of that patient. Tests ordered, so provider ordering the tests ordered are presumed to be analyzed when the results are reported. Therefore, when they are ordered during an encounter, they are counted in that encounter. So ordering the test gets counted for the day that it is ordered. Tests that are ordered outside of an encounter may be counted in that encounter in which they are analyzed. In the case of a recurring order, each new result may be counted in the encounter in which it is analyzed. For example, an encounter that includes an order for monthly prothrombin times would count for one prothrombin time ordered and reviewed. Additional future results, so not that same one, an additional one, additional future results, if analyzed in a subsequent encounter, may be counted as a single test in that subsequent encounter. Any service for which the professional component is separately reported by the physician or other qualified healthcare professional, reporting the E&M services is not counted as a data element ordered, reviewed, analyzed, or independently interpreted for the purposes of level of the medical decision making. We're going to talk more about that separately reported concept. Now again, our levels of the data reviewed are minimal or none, limited, moderate, and extensive. Minimal or none does not have any specific criteria. Now for limited, we have two different categories, and we have to meet the requirements of one of these two categories. Category 1 is tests and documents. Category 2 is assessment requiring an independent historian. If we want to meet the criteria for category 1, remember we need either 1 or 2. It doesn't have to be both in order to meet that limited criteria. For category 1, we have to meet at least 2 of these following bullets. Any combination of 2 of review of prior external notes from each unique source, review of the results of each unique test, or ordering of each unique test. And it could be 2 of the same, so 2 reviews of 2 unique tests. So let's break down each of these. So when we talk about review of a prior external note from each unique source, we have more definitions from the AMA. So the AMA has a definition for what is considered external. External is external records, communications, and/or test results from an external physician or other qualified healthcare professional, facility, or healthcare organization. We'll talk in a little bit about what is considered an external physician. Now, what's considered a unique source? A unique source is defined as a physician or other qualified healthcare professional in a distinct group or different specialty or subspecialty, or a unique entity. Every time I think about subspecialties, I always think about pediatrics, because pediatrics has so many different subspecialties underneath them. Things like peds cardiology, peds gastroenterology, pediatric endocrinology. So if the patient's general pediatrician is reviewing a note from peds cardiology, that counts because they are a different subspecialty. So that's our first bullet, that review of an external note from each unique source. So bullet 2 in category 1 is the review of the results of each unique test. Tests are imaging, laboratory tests, psychometric or physiologic data. Now, a clinical laboratory panel, if we do a whole metabolic panel on a patient, that counts as one test. Even though there's many different components of that test, it is combined all into one CPT code panel, so it counts as one test. So the differentiation here between what is a single test and what is a multiple test counts by CPT definition. And the AMA clarifies for us that a pulse oximetry does not count as a test. It is considered a vital sign. That's that little clip that they put on your finger to determine your oxygen levels. And unique test is also defined by CPT. So even if the provider is looking at multiple sets of data for like blood glucose levels, that still counts as one because it's the same test. So even if he's reviewing one from August, one from September, one from October, those are all the same test. They count once. The AMA also tells us that tests that have overlapping elements are not considered unique, even if they're identified with distinct CPT codes. The example that they give us is, it says, for example, a CBC with differential would incorporate the set of hemoglobin, CBC without differential, and platelet count. And then the third bullet is the ordering of each unique test. Now, category 2 is our assessment requiring an independent historian. Well, what the heck do we count as an independent historian, and when do we count an independent historian? So an independent historian can be an individual, so a parent, a guardian, surrogate, spouse, a witness to the event, and they provide a history in addition to the history provided by the patient because the patient is unable to provide a history or they're unreliable in providing an accurate history. It could be because of developmental stage. Maybe that it's a pediatric patient and they're not quite giving a full accurate history of what happened. It could be dementia, it could be psychosis, it could be a patient that is so heavily inebriated that they are unable to provide an accurate history and we have to get history from someone who was there to maybe witness an event. If there's a conflict between multiple historians and we need more than one historian, that's when we're meeting that criteria for sure. Now, it doesn't include translation services. And it doesn't need to be obtained in person, but it does need to be obtained directly. So maybe if you're collecting it over the phone versus face-to-face, it still counts. So that's category 1 and category 2 for the limited. Next, we'll move on to moderate. Moderate, we have 3 different categories, and we have to meet one of the 3 different categories. Category 1 basically combines everything that was in our limited into one category. So category 1 for moderate is test documents or independent historians. And then category 2 is our independent interpretation of tests, and category 3 is discussion of management or test interpretation. So for category 1 in the moderate category, where it's test documents or independent historians, again, we lumped up all the stuff we just talked about in our limited category into 4 different bullets. So bullets are review of prior external notes from each unique source, review of the results of each unique test, ordering of each unique test, or assessment requiring an independent historian. That's our category 1. Of those 4 bullets, we need a combination of 3 of them to meet the criteria for category 1. Or we could meet our category 2, which is the independent interpretation of tests. Or more accurately, the independent interpretation of a test performed by another physician or other qualified healthcare professional that's not separately reported. So we have 2 things we need to define here. First off, the independent interpretation. Second, what do we mean by separately reported? So independent interpretation, here's the definition of that. That is the interpretation of a test. Test is defined as something that has a CPT code. This does not apply when the physician or other qualified healthcare professional who's reporting that E&M service is reporting or has previously reported the test. A form of interpretation should be documented but is not needed to conform to the usual standards of a complete report for the test. Now, what about those point of care tests, the ones that are results only, something like a pregnancy test where it's either you're pregnant or you're not pregnant? Now, those tests that are results only don't count as an independent interpretation, but we can count them as either a test that was ordered or a test that was reviewed. We don't get one for ordered and one for reviewed. It's either ordered or reviewed. So that goes for your point of care testing, like your urine dips and your rapid straps. And then the definition goes on to say that the interpretation of the results of diagnostic tests or studies, so the professional component, the report, if we're doing that distinct written report, they might be separately reported using the appropriate CPT code with that 286 modifier for the professional component. So that's our category 2. Category 3 is discussion of management or test interpretation. So that's the discussion of management or test interpretation with external physician or other qualified healthcare professional or appropriate source when it's not separately reported, meaning separately billed out with a separate CPT code. The AMA actually defines for us what a discussion is, and basically it says it has to be some sort of back and forth communication, so it can't just be one provider sends an email and we think it maybe went into the abyss and we're not sure, we didn't hear anything back. It has to be that back and forth communication. It also can't be done through intermediaries, like the medical assistant picks up the phone and then relays the message to the provider. And it can't just be sending the note over or sending a note in the progress note to another provider. It doesn't need to be on the day of the encounter, but it only gets counted once. And it also doesn't need to be synchronous, but it has to be done within like a reasonable period of time, a day or two. So maybe the provider sends an email and the other provider responds the next day. Now, what's an appropriate source? An appropriate source is someone who's involved in this patient's care, but they're not a healthcare professional. It could be like a parole officer. It could be a lawyer, a case manager, a teacher. It just can't be those independent historian people, like a parent, where they're just providing history. That's where we meet that independent historian criteria, not necessarily discussion of that patient case with a appropriate source. And we said this could be a discussion with an external physician. So an external physician is one who is not in the same group practice or is a different specialty or subspecialty. And this includes licensed professionals who are practicing independently. The individual may also be a facility or organizational provider, such as from a hospital, nursing facility, or home health care agency. So that's our moderate. We have to meet at least one of those 3 different categories. Now, the highest level would be the extensive, and the extensive is just about the same as the moderate with one difference. Out of those 3 categories, instead of just meeting one of the 3 categories, we have to meet 2 of the 3 categories to hit extensive. The categories are the same. Category 1 is tests, documents, or independent historians. Category 2 is independent interpretation of tests. And then category 3 is our discussion of management or test interpretation. I think you can see now why a lot of people don't like the data component. There are some auditing tools out there that can make it a little bit easier and maybe help you kind of wrap your head around it, like the ones that Novitas has. I'll try to remember to link those below as well. In the next video, we are going to go over the risk component. Risk is a heck of a lot easier than data. So I will see you guys in the next video. And until then, just keep on coding on.